Bronchitis. The basics. Definition, pathophysiology, and etiology. 1. Definition. Inflammation of the bronchial tubes. Inflammation of the airways. Bronchitis is defined as the inflammation of the bronchial tubes, the airways that carry air into the lungs. Acute or chronic. Can be classified as either acute, short-term, or chronic, long-term. Note: the key feature is inflammation of the airways and its clinical manifestations. 2. Pathophysiology. The mechanisms of airway inflammation, acute bronchitis, viral infection. The most common cause due to viruses such as rhinovirus, influenza, adenovirus, or respiratory syncytial virus, RSV. Inflammatory response. The viral infection triggers inflammation of the bronchial lining, leading to increased mucus production, airway swelling, and bronchospasm. Note: the inflammatory response is an important part of the pathophysiology. Chronic bronchitis, chronic irritation, typically caused by chronic exposure to irritants, especially cigarette smoke. Inflammation results in chronic inflammation of the airways. Hyperplasia of mucus glands, increased mucus production leading to a productive cough. Airway narrowing. Chronic inflammation and repeated irritation cause structural changes in the airways, airway remodeling, leading to airway narrowing and airflow limitation. Ciliary dysfunction. Chronic inflammation can impair the function of cilia, the small hair-like structures that help to clear mucus from the airways, leading to increased mucus production and poor clearance. Note: this is a combination of chronic inflammation and structural changes in the lung tissue. Note: the pathophysiology is different for acute and chronic bronchitis. 3. Etiology. What causes bronchitis? Acute bronchitis, viral infections. As stated earlier, respiratory viruses are the most common cause. Bacterial infections. Less commonly, Mycoplasma pneumoniae, Chlamydia pneumonia, or Bordetella pertussis, whooping cough, can also cause acute bronchitis. Note: usually associated with an upper respiratory tract infection. Chronic bronchitis. Smoking. By far the most common cause of chronic bronchitis that causes the chronic irritation of the airways. Occupational exposures. Chronic exposure to dusts, fumes, or chemicals. Air pollution. Long-term exposure to air pollution. Note: understanding the causes helps to understand the differences in acute and chronic bronchitis. Clinical manifestations and diagnosis. Recognizing and investigating bronchitis. 1. Clinical manifestations. Recognizing the signs and symptoms. Acute bronchitis. Cough. The most common symptom, which is typically a dry cough initially, that may become productive with mucus after several days. Sputum production. Usually clear but can also be white, yellow, or green. Rhinorrhea, nasal congestion, and drainage. Sore throat, malaise, fatigue, and general discomfort. Low-grade fever. Mild fever may be present. Wheezing may be present due to inflammation. Chronic bronchitis. Productive cough. Chronic cough that is persistent and productive with sputum for at least 3 months of the year for at least 2 consecutive years. Dyspnea. Shortness of breath, especially with exertion. Wheezing may be present. Increased sputum production, excess sputum production. Note: the clinical presentation varies based on the type of bronchitis and the severity of the disease. 2. Diagnostic workup, a step-by-step approach. History and physical examination. Thorough history of symptoms, past medical history, and smoking history, along with a full respiratory physical exam. Note: diagnosis is mainly clinical. Acute bronchitis. Usually no specific testing. In most cases, specific diagnostic tests are not required. Rapid viral testing may be done in some cases to rule out specific viruses if necessary. Note: specifically done during an outbreak or in high-risk individuals. Note: testing should be guided by the clinical suspicion. Chronic bronchitis. Spirometry, pulmonary function tests, to assess for airflow limitation. Note: to determine if there is a component of chronic obstructive pulmonary disease, COPD. Chest X-ray may be performed to rule out other conditions. Note: lab testing is not usually required for diagnosis. Note: the diagnosis is primarily based on clinical findings and patient history of symptoms. Management. Strategies for treating bronchitis. 1. Acute bronchitis. Primarily supportive care. Symptomatic relief, rest, hydration, analgesics, over-the-counter pain relievers such as acetaminophen or ibuprofen to reduce fever and pain. Cough suppressants. Cough medications may help to suppress a non-productive cough, but use should be with caution. Expectorants. Guaifenesin can help to loosen mucus. Antibiotics. Not typically recommended. Antibiotics are typically not needed and are not recommended for most cases of acute bronchitis because the majority of infections are due to viral etiologies. Limited use should only be considered in cases of suspected bacterial pneumonia or underlying medical conditions that increase the risk of complications. Note: most cases of acute bronchitis are self-limited and will resolve on their own with supportive care. Note: treatment is mostly symptomatic and limited evidence to support medications such as cough suppressants and expectorants. 2. Chronic bronchitis, long-term management, smoking cessation, the most effective measure to prevent progression of chronic bronchitis. Note: counseling, nicotine replacement, and other medications are available for support. Bronchodilators. Short-acting beta-2 agonists, long-acting beta-2 agonists, and anticholinergics to relieve bronchospasm, improve airflow, and reduce shortness of breath. Inhaled corticosteroids. Inhaled corticosteroids may be used in combination with long-acting bronchodilators to reduce inflammation. Note: limited benefit in chronic bronchitis but are useful to treat underlying asthma. Pulmonary rehabilitation, exercise training and education to improve exercise tolerance and quality of life. Oxygen therapy. Supplemental oxygen may be required in patients with severe hypoxemia. Antibiotics can be used to treat bacterial exacerbations. Note: management focuses on preventing disease progression and management of exacerbations. 3. Prevention, reducing risk factors. Smoking cessation, essential for preventing chronic bronchitis. Vaccinations. Annual influenza vaccine and pneumococcal vaccine to reduce the risk of serious respiratory infections. Avoid irritants, limiting exposure to air pollution and other environmental irritants. Note: lifestyle modifications are the key to prevent disease. Long-term considerations. The big picture. 1. Monitoring for exacerbations, regular monitoring for symptoms and exacerbations of chronic bronchitis. 2. Management of complications, treatment of pneumonia and respiratory failure that may occur. 3. Lifestyle modifications, smoking cessation and avoidance of irritants is key. 4. Patient education. Educate patients on the underlying condition, medication management, and self-management strategies. Key takeaways for exam success and future practice. 1. Bronchitis is defined as inflammation of the bronchial tubes and can be classified as acute or chronic. 2. Acute bronchitis is most often caused by a viral infection, while chronic bronchitis is most often due to smoking. 3. Understand the pathophysiology of both acute and chronic bronchitis and the differences. 4. Recognize the common clinical manifestations: cough, sputum production, and other respiratory symptoms. 5. Understand the main differences between acute and chronic bronchitis. 6. Be able to manage both acute and chronic bronchitis with supportive care and medications, but know that there is limited use of antibiotics for acute bronchitis. 7. Smoking cessation and patient education are important for both treatment and prevention.